Welcome back to the deep dive. Today, we are really tackling some challenging material. We've got surgical textbook excerpts, and we're doing a deep dive into the surgical anatomy of the brainstem and the pineal region.
Yeah, this isn't just tough. It's arguably the most complex, most functionally critical area in the entire central nervous system.
The inner sanctum, you called it before we started.
Exactly.
Yeah.
It really is. And for the elite professionals in this field, mastering this isn't just about knowing the parts. It's about understanding the sheer functional density. You're operating within millimeters, literally millimeters, where tracks for motor control, sensation, consciousness, basic life support, they're all converging.
So our mission today, for you listening, is to take this incredibly dense, granular information and, well, make it stick. Turn it into applicable knowledge.
That's the goal.
Okay, challenge number one, the brainstem itself. I mean, it runs through both the supra and infratentorial spaces. It's got all the major motor and sensory highways running through it, plus those essential autonomic and cranial nerve nuclei.
It's like a massive critical traffic jam, isn't it? Everything has to pass through there.
And then there's the pineal gland. Tiny little thing, relatively speaking.
Small but mighty in terms of surgical challenge. Its location, it's just a three-dimensional geometric nightmare. It's right up against the confluence of those deep veins draining the basal ganglia, the deep cerebrum. Getting in there is, it's an exercise in incredibly complex neurovascular preservation.
Okay, so to navigate this terrain, our sources lay out some specific surgical corridors. For the brainstem itself, for intrinsic lesions and the posterior fossa, there are four main approaches we need to master.
Right. First, the midline suboccipital craniotomy. That's mainly aimed at the cerebellum and getting into the fourth ventricle.
Then the retrosigmoid craniotomy. That gives you access to the lateral cerebellum and, importantly, the cerebellopontine angle, a really busy area.
Very busy. And for the tougher spots, the ventral or superior lesions, you need more specialized routes. The far lateral approach gets you to the ventral brainstem, especially the medulla and the cervicomedullary junction.
And the big one, the cranio-orbitozygomatic approach. That's designed for the upper brainstem, the midbrain, trying to get there with minimal brain retraction.
It's extensive, yeah. And for the pineal region, with all that venous complexity, the approach selection is even stricter. There are three core ones.
Okay, lay them out.
The supracerebellar infratentorial approach. Then, the occipital intrahemispheric transtentorial approach. And finally, the posterior transcallosal approach.
And we'll get into how the position of those major veins, how they're displaced, really dictates which one you choose.
Exactly. It's all about the veins in that region.
All right, let's unpack this. Where should we start? The fourth ventricle seems central.
I think so. It's right in the middle of the posterior fossa, and unfortunately, it's a very frequent site for brain tumors, particularly in kids. Medulloblastoma is a classic example you see mentioned.
And the sources highlight how much things have changed recently. Technology, high-res MRI, image-guided surgery, microsurgery, it's all led to much better long-term outcomes, especially for focal lesions like gliomas and cavernomas in this really critical area.
Oh, absolutely. The progress has been staggering. But maybe the biggest leap in safety has come from integrating diffusion tractography, DTI.
Right. This isn't just looking at structure, is it?
No, not at all. DTI lets the surgeon actually visualize the functional pathways. You see the corticospinal tract, for instance. Map it out relative to the tumor. That's absolutely indispensable for planning the safest way in, the safest corridor, and hopefully avoiding devastating neurological deficits after surgery.
Okay, so let's ground ourselves in the basic anatomy first. The ventricle itself. You described it as a rhomboid structure.
Yeah, that's the classic description. It's basically diamond-shaped, sitting there in the posterior fossa. The boundaries are key.
Yeah.
The brainstem is anterior, forming the floor, the very eloquent, dangerous floor. And the cerebellum sits posteriorly, forming the roof and walls.
It's like the central meeting point for everything back there.
Pretty much. And its connections, the waterways as you put it, are vital for CSF. Rostrally, at the top apex, it connects to the third ventricle through the cerebral aqueduct. Caudally, at the bottom, CSF flows out into the posterior fossa cisterns through the foramen of Magendie. That's right in midline.
And laterally.
Laterally, at its widest point, you have the paired foramina of Luschka. These open right out into the cerebellopontine angles.
So aqueduct in, Magendie, and Luschka out.
Basically, yes. And you can immediately see why lesions here cause hydrocephalus so quickly. They block those outflow paths.
Right. Now, the floor, the part that, as the source material implies, keeps surgeons awake at night.
No, yeah, that's fair. The eloquent floor is the dorsal surface of the brainstem, We usually divide it sort of conceptually into the rostral 2/3, which is the pons, and the caudal 1/3, the medulla.
And there are clear landmarks on this floor.
Oh yes, running right down the middle is the median sulcus, divides it left and right. Then running parallel to that is the sulcus limitans. This divides the floor into a medial section, the median eminence, and a lateral section, the vestibular area.
And the functional density in that median eminence, it's
Yeah.
incredible.
It really is. Rostrally, towards the top, the median eminence bulges out a bit. That's the facial colliculus. It's a visible bump, and it sits right over the ascending fibers of the facial nerve, CNZ7th, as they loop over the nucleus of the abducens nerve, CNZ.
Two critical nuclei, 7 and 6, right there under that bump.
Exactly. It's a crucial landmark for knowing where those nuclei are buried.
And moving down caudally within that same eminence.
You hit a cluster of absolute life support functions. The hypoglossal nucleus for tongue movement, CN12, the vagal nucleus, CNX, vital for autonomic control, heart rate, gut function, and the area postrema, just rostral to the very bottom tip, the obax, that's the brain's vomiting center, detects toxins.
Wow.
Yeah.
So disrupting any of that,
Yeah.
immediate severe consequences.
Absolutely immediate. And then moving laterally from the midline, you have the vestibular area. That, unsurprisingly, overlies the vestibular nuclei for balance. These extend out into the lateral recesses of the ventricle.
And right at the edge.
Right at the most lateral part, near where the foramina of Luschka open, the cochlear nuclei form another little prominence, herring function.
Are there any other key landmarks on the floor?
Yeah, the stria medullaris. These are little fibers you can sometimes see running transversely, extending medially from near the Luschka region and sort of disappearing into the median eminence. They're another helpful visual cue.
Okay, that's the floor. Let's flip it over and look at the roof. It's described as pyramidal, right? With an apex called the fastigium.
Correct. The upper half of this pyramid is formed by the superior medullary velum. It's just a thin sheet of white matter connecting the two superior cerebellar peduncles. And sitting dorsally, right on top of this velum, is a little piece of the cerebellar vermis called the lingula.
In the lower half.
That's the inferior medullary velum. It's continuous with the superior velum up at the fastigium. Its crucial attachment is to the telochoroidea at what's called the telovelar junction.
Telochoroidea. That sounds important.
It is, because the telochoroidea is the membrane that carries the choroid plexus, the stuff that makes CSF. And the natural gaps or holes in this tela are actually what form the foramen of Agundi in the midline and the foramina of Luschka laterally.
Ah, okay. So the roof structures literally define the exit holes.
Precisely. And focusing on Luschka is really important for lateral approaches. The foramina sit just caudal to the cerebellar peduncles. In fact, the inferior cerebellar peduncle forms the rostral wall of the foramen.
Any landmarks right there at Luschka?
Yes, the flocculus. It's a small, sort of cauliflower-shaped bit of cerebellum that extends out from the telochoroidea near the foramen. It's a very reliable surgical landmark. If you see the flocculus, you know you're right near Luschka.
And this whole lateral recess area is packed with nerves, isn't
It's
it?
absolutely packed. You've got the vestibulocochlear nerve, CN8th, crossing the floor nearby. The facial nerve, CN bigidus, emerges just superiorly. And the glossopharyngeal, CNIX, and vagus, CNX, nerves arise ventrally, very close to the foramen. It's crowded.
Okay, one more structure before we talk approaches. The cerebellar tonsils, how do they fit in?
The tonsils are important because they kind of form a natural barrier hanging down and covering the lower part of the fourth ventricle cavity. They're separated from the medulla underneath by a space called the cerebellomedullary fissure. The ventral, or front surface of the tonsil, lies right over those lower roof structures, the inferior medullary velum and the tela.
And deep inside the cerebellum near the tonsils.
Right, just rostral or slightly above the superior pole of the tonsil lies the dentate nucleus. This is the biggest of the deep cerebellar nuclei. And it's functionally connected, very importantly, to the brainstem.
How so?
Well, its main output tract, the dentothalamic tract, travels up within the superior cerebellar peduncle towards the thalamus. But here's the crucial alignment, the thing you really need to lock in for mastery. The anatomical level of the dentate nucleus corresponds almost exactly to the level of the facial colliculus, and therefore the abducens nucleus in the floor of the fourth ventricle.
Wow, okay. So dentate nucleus level equals facial colliculus abducens level. That's a key spatial relationship.
A vital one.
Yeah.
Knowing that specific alignment and knowing the path of that dentatothalamic tract, that's the hinge. That's what pivots us right into talking about the problems when things get displaced and how surgical approaches have evolved to deal with that.
Because displacement isn't just moving things around visually, is it?
Not in the brainstem, no. Given the density we just talked about, especially on the floor, displacement is a functional crisis. Tumors, particularly things like pontine gliomas, can radically distort these structures. They might push the facial nerve nucleus way out, wrap it around the mass ventrally.
Which makes relying just on visual anatomy impossible.
Utterly impossible. You absolutely need meticulous intraoperative neurophysiological monitoring. Mapping. You have to stimulate electrically to find out where these compressed, displaced nuclei actually are, especially once you start resecting. This is critical for lower cranial nerves and medullary tumors, too.
And this inherent risk, this functional density, leads directly to the most feared complication of fourth ventricle surgery, posterior fossa syndrome, PFS.
Yes, PFS. The figures are sobering, reported up to 25% of these resections. The classic triad is mutism, where the patient just cannot speak, severe ataxia, problems with coordination, and significant emotional lability.
Who's most at risk?
Risk factors are pretty well established. Young age, especially under 5. Large tumors. And specifically, medulloblastoma pathology seems to carry a higher risk. And while we used to hope it was always transient,
It often isn't.
sadly no. Studies show these deficits, particularly the ataxia and cognitive or emotional changes, can persist long-term, sometimes severely impacting quality of life.
What's the thinking on why it happens? What's the mechanism?
The prevailing theory centers right on that pathway we just identified,
Yeah.
the dentatorothalamic tract. Injury to this critical cerebellar output pathway, whether it's direct surgical trauma or maybe swelling or vascular compromise, is thought to cause what's called a diaschisis syndrome. Essentially, there's an acute shutdown of input from the dentate nucleus going up to the thalamus and then onto the cortex, particularly the motor system. And that sudden functional disconnection manifests as the mutism and ataxia.
And there's that interesting finding on long-term imaging.
Right. Patients who develop PFS often show hypertrophy, like an enlargement of the inferior olivary nucleus later on. It suggests some kind of long-term reaction or maybe attempted compensation within the cerebellar circuits following that primary injury to the dentate outflow.
So this high risk of PFS really drove the evolution away from traditional techniques.
Absolutely. The classic traditional way in was the transvermian approach. This literally involves splitting the cerebellar vermis, the midline part of the cerebellum, especially the lower vermis.
And that caused problems.
Yes. That surgical trauma to the vermis itself was directly linked to postoperative ataxia, and by extension, strongly suspected in causing PFS. Splitting the midline gave a wide, direct view, yes, but the cost, the vermian injury, was just too high.
Which led to the modern alternative.
The telovelar approach, the vermis-sparing approach.
And the rationale is straightforward. Save the vermis, hopefully reduce the risk of PFS.
That's the core idea. And it's compelling. We should note, the literature isn't 100% unanimous that it always prevents PFS, but the argument is strong enough and the potential benefit significant enough that it's become the preferred first-line approach for most lesions.
So technically, how do you do it? How do surgeons find that plane without cutting the vermis?
It's about careful dissection in the natural cleavage planes. You go through the cerebellomedullary fissure, that space between the tonsil and the medulla. Specifically, you find the plane between the medial side of the tonsil and the lateral surface of the uvula, which is part of the vermis.
Okay.
Once you're in that fissure, you carefully incise the membranes forming the lower part of the roof, the inferior medullary velum, and the telochoroidea. This opens up the ventricle from below, without splitting the midline cerebellum.
And the advantages seem clear, beyond just saving the vermis.
Right. You get early visualization and, therefore, protection of the ventricle floor and those critical cerebellar peduncles. You can often identify the PASIA, the posterior inferior cerebellar artery, early on, which is huge for controlling bleeding, especially in small children where blood loss is critical.
Access to the sides, too.
Yes, much better access to the lateral recesses and the foramen of Luschka compared to the midline transvermian route. And another potential benefit, by creating a really wide opening down at the foramen of Mangetti, it might help prevent postoperative hydrocephalus and reduce the need for a permanent shunt.
But as you said, no approach is perfect. If telovelar is so good, why would anyone still consider the transvermian? What are the limitations?
The main limitation seems to be access to the very top, the rostral third, and the fourth ventricle. Some comparative studies suggest that for tumors really centered high up near the aqueduct, the traditional transvermian split might still offer slightly better visualization and maybe higher rates of complete resection.
So the exact location within the ventricle still matters.
Absolutely. It underscores that mastery isn't just knowing the best technique, it's knowing when each technique is truly optimal, based on the specific tumor's location and extent. Sometimes the old way still has a role for very specific situations.
That's a critical point. Okay, let's shift our focus laterally and maybe a bit superiorly now. The cerebellopontine angle, the CPA. You called it a busy neighborhood.
Huh. Yeah, it really is. Cranial nerves, IV through STI, are all found in or passing near the CPA.
But there's an organizational principle, right? It's not just chaos in there.
Thankfully, no. The contents are quite nicely structured into 3 neurovascular bundles, stacked vertically.
Okay, top level.
Superior complex. Superior cerebellar artery, the SCA, running right alongside the trigeminal nerve, CNV.
Middle level.
Middle complex. Anterior inferior cerebellar artery, AICA, intimately associated with the facial acoustic bundle, that's CNSEC, the facial nerve, and CN8, the vestibulocochlear nerve.
And the bottom level.
Lower complex. Posterior inferior cerebellar artery, PICA, coursing with the lower cranial nerves, EIX, glossopharyngeal, X vagus, and eclotic accessory.
And knowing this structure helps predict pathology.
Definitely. Think about it. Neurovascular conflict, a little artery loop, compressing a nerve. If it happens in the upper complex, hitting the trigeminal nerve. Classic cause of trigeminal neuralgia.
Makes sense.
If you have a tumor growing in the middle complex, right on the V8th bundle, that's the absolute classic location for a vestibular schwannoma. So the anatomy immediately points you towards likely diagnoses based on symptoms.
And the main surgical highway into the CPA.
That's the retrosigmoid approach.
Positioning is key here, you mentioned. Park bench.
Typically park bench, yeah, or supine with the head turned and flexed. The goal is to let gravity help retract the cerebellum slightly once CSF is trained.
And the crucial first step is finding the right spot on the bone.
Absolutely. You have to define the transverse sigmoid junction, where the transverse sinus meets the sigmoid sinus. The surface landmark for that is the asterion. You can approximate it by drawing a line back from the zygoma, and it's usually about 1/3 of the way down the ear. Precision matters here.
And a huge safety point, drain CSF before touching the cerebellum.
Mandatory. Absolutely mandatory. You must drain CSF from the cisterna magna first. If you don't, and you try to retract the cerebellum, you put significant stretch on those cranial nerves emerging from the brainstem. That's how you can cause deafness, for example, during a microvascular decompression for hemifacial spasm. Drain first, retract gently.
Got it. Okay, moving higher now. Let's tackle the midbrain, the mesencephalon. Getting to intrinsic lesions there seems really challenging. 2 main routes, ventral and lateral.
Correct. Very different approaches. The ventral approach needs that big cranio-orbitozygomatic exposure we mentioned earlier.
Remind us what that involves.
We're removing the orbital rim, the roof of the orbit, the zygomatic arch, plus the standard terrenal craniotomy. It sounds drastic, but it's necessary to get a really low, flat trajectory to the ventral midbrain without having to dangerously retract the frontal lobe.
And the path once the bone is removed.
It's intricate. You follow the middle cerebral artery back to the carotid bifurcation, identify the third nerve, the oculomotor nerve, CN3. Then you use the borders of the oculomotor triangle, which is formed by nerves and vessels, to aim towards the interpeduncular fossa, the space between the 2 cerebral peduncles and the peduncle itself.
But there's a major no-go zone here.
A critical one. The source material is very clear. Dissection in the interpeduncular cistern itself is best avoided. It's just too dangerous. It's packed with the origins of both third nerves, plus a dense network of tiny perforating arteries coming off the posterior cerebral artery, the basilar artery, the superior cerebellar artery. Hitting those causes catastrophic stroke or hemorrhage.
So where can you safely enter the midbrain from the front?
The designated safe entry zone is the anterior mesencephalic zone. This is actually on the cerebral peduncle itself. You have to stay lateral to the oculomotor nerve as it emerges, and medial to the main bulk of the pyramidal fibers, the corticospinal tract, which runs in the lateral part of the peduncle. It's a narrow window.
Okay, that's ventral. What about that lateral approach, subtemporal route?
Right. This involves coming in from the side, under the temporal lobe. You open the arachnoid membrane in the middle or anterior part of the incisional space, the space around the brainstem where it passes through the tentorial opening. Then you have to divide the tentorium, the dural shelf, just lateral to where the 4th nerve, the trochlear nerve, CNIV, is running.
And the safe entry zone from this angle?
It's the lateral mesencephalic sulcus. This is a groove that runs down the side of the midbrain, roughly from the medial geniculate body, part of the auditory pathway, down to the pontomesencephalic junction, where the pons meets the midbrain.
What are the specific risks with this lateral subtemporal approach?
2 main ones stand out. Injury to the vein of Labbé, a large vein draining the temporal lobe, which can cause venous infarction and swelling. And because you're working right near them, oculomotor morbidity, potential damage to both the third and fourth nerves.
Okay, descending again. Let's nail down the safe entry zones for the pons and the medulla. This is for getting at intrinsic lesions, right? Like cavernomas or maybe small gliomas.
Exactly. For the pons, the key zone for anterolateral access is the epitrigeminal region. It's a spot on the front side surface of the pons, safely anterior to the trigeminal nerve root as it enters, and importantly, lateral to the corticospinal tract running inside the pons.
And how do you get there? What's the approach?
The best way to reach that specific zone is via the Kawase approach. That's an anterior petrosectomy, meaning drilling away part of the petrous temporal bone.
The drilling target is very specific.
Very specific. You drill the bone that's anterior to the internal auditory canal, medial to the greater petrosal nerve, and posterior to the mandibular division V3 of the trigeminal nerve. It's precise bone removal to open that window.
You mentioned the greater petrosal nerve there. What happens if that gets injured during the Kawase approach? That seems like a crucial detail.
It is. That's exactly the kind of granular knowledge needed. The greater petrosal nerve carries parasympathetic fibers heading for the lacrimal gland. So injury to it causes a dry eye on that side, reduced tear production. It's a known potential morbidity of that approach that patients need to be aware of.
Okay, that's anterolateral pons. What about accessing the pons from the back, posteriorly?
Then you're back on the floor of the fourth ventricle. And given how eloquent that floor is, as we discussed, you absolutely must use intraoperative neurophysiological mapping. You cannot rely on visual landmarks alone back there for intrinsic lesions.
But even with mapping, there are relatively safer zones.
Relatively safer, yes. Two main ones are described. First, the supracollicular area. This is above the facial colliculus. It's bordered medially by the median longitudinal fasciculus, MLF, important for eye movements, and laterally by the superior cerebellar peduncle.
And the second one?
The infrafacial region. This is below the facial colliculus, bordered superiorly by the colliculus itself, medially again by the MLF, and inferiorly by those stria medullaris fibers we mentioned.
These zones are safer because they avoid the densest clusters of nuclei.
Essentially, yes. They offer slightly less functional density than cutting right into the facial colliculus, for example. But we're talking fractions of a millimeter between relative safety and causing a major deficit like facial palsy or gaze problems. Mapping is still key.
Understood. Now, down to the very bottom. The medulla oblongata. How do we get in there?
Standard approaches like the telovelar, transvermian, or retrosigmoid can give you posterior access.
And the safe entry zones within the medulla itself.
Two main ones again. First, the lateral medullary zone. This is sometimes called the inferior cerebellar peduncle approach. The zone is located inferior to the cochlear nuclei and posterior to where the glossopharyngeal IX and vagus X nerves emerge. You'd access this via a telovelar or retrosigmoid route, typically.
And the other posterior zone.
That's simpler. The posterior median sulcus, right at the midline at the very bottom, the obex. This is basically just extending a midline spinal cord approach upwards. The main restriction here is laterally you have to stay medial to the gracile nuclei, which are part of the sensory pathways.
And the risks down here in the medulla are profound, right? Breathing, swallowing.
Extremely profound. Medullary surgery carries high risks of hypopnea, shallow breathing, respiratory failure, and vocal cord paresis from vagal nerve injury. High stakes.
What if the lesion is on the ventral side of the medulla, or at the junction with the spinal cord?
For those ventral or cervicomedullary lesions, you need the far lateral approach. This is another extensive approach.
Describe that one.
It usually starts with a hockey stick incision in the skin. The key is exposing the suboccipital triangle because that's where the vertebral artery loops before entering the skull. The bone removal involves taking off the ipsilateral half of the posterior arch of C1, the first cervical vertebra. Often, you need to remove bone lateral to the foramen magnum as well, sometimes even part of the occipital condyle, though surgeons try to avoid that if possible, especially for brainstem tumors.
Is there a key maneuver to get enough exposure?
Yes. Dividing the dentate ligament, a little ligament that anchors the spinal cord right where the vertebral artery enters the dura. Cutting that ligament allows the spinal cord and medulla to be gently mobilized, giving you the window you need to the ventral surface.
And once you have that ventral view, where can you make an incision into the medulla itself?
There are two potential corridors going either in front of or behind the olive that bump on the side of the medulla. The anterolateral sulcus runs along the frontage of the olive. You can enter there between the rootlets of the hypoglossal nerve and the C1 nerve root. But this is very close, dangerously close, to where the pyramidal tracts cross over the decussation. High risk of motor deficit.
And the other option?
The posterior olivary sulcus. This is the groove behind the olive, between the olive and the inferior cerebellar peduncle. It's generally considered a slightly safer corridor for accessing intrinsic lesions from the ventral side via the far lateral approach.
Wow. Okay, we've navigated the brainstem highway. Now we need to pivot to that other incredibly complex area, the pineal region and the deep venous labyrinth there.
Right. The pathology here is really diverse. You see germ cell tumors, pineal parenchymal tumors from the gland itself, gliomas extending from nearby structures, benign cysts, even vascular malformations.
But the first problem is often hydrocephalus, isn't it?
Very often. The pineal gland sits right near the back of the third ventricle and the entrance to the cerebral aqueduct. So lesions there frequently block CSF flow, causing obstructive hydrocephalus.
And that dictates the initial management strategy.
Usually, yes.
Yeah.
Endoscopic third ventriculostomy, ETV, is the standard first step. You create a new pathway for CSF to bypass the blockage. And often, during the same ETV procedure, the surgeon can take an endoscopic biopsy of the lesion.
Is biopsy always needed?
Not necessarily. There's a crucial diagnostic shortcut. If blood tests or CSF analysis show elevated levels of specific tumor markers, alpha-fetoprotein, AFP, or beta-human chorionic gonadotrophin, HCG,
Yes.
that strongly points towards a malignant germ cell tumor, like a germinoma or something more aggressive. In those cases, the team might proceed directly to treatment like radiation or chemotherapy, potentially avoiding a major resection or even the need for a biopsy right away.
But if those markers are negative,
Then you absolutely need a tissue diagnosis. You have to know what you're dealing with. Stereotactic biopsy is one option, using a needle guided by imaging. But open biopsy, usually via one of the approaches we'll discuss, gets a larger, more representative sample. That's important because pineal tumors can often be mixed with different components.
and you always have to rule out a simple pineal cyst.
Right. These are actually quite common, seen in maybe up to 4% of normal MRI scans. They're typically small, under 2 centimeters, and might have a thin enhancing rim on the scan. Got to distinguish those benign findings from actual tumors.
Okay, let's talk surgical anatomy. The gland itself, it's extraaxial.
Generally, yes, meaning it sits outside the brain tissue proper, usually allowing for a surgical plane to be developed between the tumor and surrounding structures, like the thalamus or brainstem. However, if the tumor is already infiltrated into those structures, resectability becomes much more limited, obviously.
So looking at it from the quadrigeminal cistern, the space where the surgeon is working, what are the boundaries?
Superiorly, you've got the splenium of the corpus callosum, the back end of that big white matter tract connecting the hemispheres. Laterally, you have the thalami on either side. Inferiorly is the quadrigeminal plate, that's the roof of the midbrain, with the superior and inferior colliculi and also the top part of the cerebellar vermis.
Any other critical structures right there?
Oh yes, you have to remember the trochlear nerve, CNIV. It's the only cranial nerve that exits dorsally, wraps around the brainstem, and runs forward in the ambient cisterns right below the inferior colliculi and the pulvinar, part of the thalamus. It's incredibly vulnerable during approaches to this region.
Okay, now, the venous system, the real maze.
The absolute crux of the matter. The roof of the quadrigeminal cistern is basically defined by the deep veins, and they're encased in thick, often unforgiving arachnoid membranes.
These veins drain the deep brain structures?
Exactly. They're continuous with the internal cerebral veins, the ICVs. Now, the ICVs themselves are formed a bit more anteriorly, just behind the foramen of Monroe, where the anterior septal and thalamostriate veins join up.
Okay.
Then these two ICVs run backward, within the roof of the third ventricle and the telochoroidea, and they tend to diverge slightly as they pass over the top of the pineal gland.
And they drain into the vein of Galen.
Precisely. The great vein of Galen is formed right there, in the quadrigeminal cistern. It's formed by the confluence, the joining of the two internal cerebral veins, and crucially, the two basal veins of Rosenthal.
Where did the basal veins come from?
They drain structures around the base of the brain and course backward through the ambient cisterns, making a sharp turn around the cerebral peduncles to join the ICVs and form the vein of Galen.
And the vein of Galen itself?
It's actually quite short, surprisingly, maybe 4 to 15 millimeters long. It then dives upward to join the inferior sagittal sinus, and together they form the straight sinus, right at the junction of the falx and the tentorium.
So ICVs plus basal veins form Galen. Galen plus inferior sagittal sinus form the straight sinus.
You got it, a critical confluence.
Now, the obvious question. The brain usually has lots of collateral venous flow. Why is injury to these deep veins so catastrophic?
Because of what they drain. The ICVs and the basal veins are the primary drainage for the most critical deep structures. The basal ganglia, the internal capsule, the thalami. While there might be some superficial collaterals damaging these main deep collecting veins, especially the ICVs,
Leads to.
immediate high risk of venous infarction, basically a stroke caused by blocked drainage and potentially massive hemorrhage within those deep nuclei. The neurological consequences are profound, often devastating, potentially fatal. Preserving these veins isn't just important, it's absolutely paramount, non-negotiable.
Okay, so given that extreme risk, the choice of surgical approach hinges almost entirely on where the tumor is relative to these veins.
100%. That's the deciding factor. The most common situation anatomically is that the tumor pushes the big veins, the ICVs and vena of Galen, superiorly and dorsally up and back.
And in that case?
In that case, the supracerebellar infratentorial approach is favored. You're coming in from below the cerebellum and below the tentorium, looking up towards the pineal region. The tumor is sitting below the critical venous layer, giving you a clearer, safer path to it.
But this approach often uses the sitting position, which has its own risks.
It does. The sitting position is beneficial because gravity helps the cerebellum and the tumor drop down, away from the veins, and it aids drainage of CSF and blood. The surgeon often flexes the patient's head, so the tentorium is almost parallel to the floor.
But the risks are significant. Air embolism.
That's the big one. Air getting into an open vein and traveling to the heart and lungs. Detecting a drop in the patient's end-tidal CO2 is the standard way to monitor for it intraoperatively. And you absolutely must screen patients beforehand for a patent foramen oval, a PFO, a small hole between the heart chambers.
Why is the PFO screen so critical?
Because if air gets into the venous system and the patient has a PFO, that air can cross over into the arterial circulation and go straight to the brain, causing potentially massive strokes. Other risks of the sitting position include pneumocephalus, air trapped in the head, and subdural hemorrhage if the brain drops too much. And hemostasis, stopping bleeding, has to be meticulous because the venous pressure is so low.
Okay, so assuming the sitting position is managed safely, what does the supracerebellar approach involve?
A craniotomy, just below the transverse sinuses. Open the dura, often in a Y shape. Carefully drain CSF to let the cerebellum settle. You might need to divide some small veins or adhesions on the top surface of the cerebellum, like the precentral cerebellar vein, to open up the corridor.
And then you see the tumor.
Usually, yes. You look up below the tentorium, and the tumor is typically visible beneath a thickened arachnoid covering the quadrigeminal cistern. Critically, the vein of Galen and the ICVs are seen above the tumor mass, allowing you to work below them and protect them.
Any other structures to watch out for?
Remember the trochlear nerves, CNIV. They run laterally, near the free edge of the tentorium. Got to avoid injuring those.
Okay, that's approach number one for tumors below the veins. What if the veins are displaced downwards, or the tumor is really large, going above the tentorium?
Then you need a different route. That's where the occipital interhemispheric transdentorial approach comes in. This is ideal for lesions that are above the vein of Galen, maybe centered right at the tentorial edge or involving the back of the thalamus, the pulvinar, or the medial occipital lobe.
How is the patient positioned for this?
Usually 3/4 prone or park bench. The head is elevated and rotated, so the occipital lobe on the side of the approach is dependent, again using gravity to help it fall away laterally, minimizing the need for retraction.
And retraction is a big issue here, right? Because of vision.
Huge issue. You must use IV mannitol or drain CSF aggressively to relax the brain and mobilize the occipital lobe. Even seemingly minor retraction on the occipital lobe, especially the pole, can cause a heminopia loss of half the visual field. And retracting the very back, the occipital pole, specifically risks compromising central foveal vision. Devastating complication.
So the procedure itself, what gets opened?
You do a craniotomy that exposes the posterior part of the sagittal sinus and the top edge of the transverse sinus. You come down between the occipital lobes. The key step is then incising the tentorium, usually about 1 centimeter lateral to the straight sinus and parallel to it. Cutting the tentorium opens the door from the supratentorial space down into the pineal region.
And the view.
Gives you excellent vertical exposure. You can see from the splenium above all the way down the brainstem below. You remove the tumor piece by piece, carefully navigating that critical triangle formed by the vein of Galen, the straight sinus medially, and the basal veins running laterally.
How does it compare to the supracerebellar view?
The transdentorial view gives you better visualization of the posterior fossa structures on the same side as your approach, the cerebellum cephalic fissure, the ambient cistern. but you typically get a poorer view of the opposite side of the quadrigeminal cistern compared to the supracerebellar route. Trade-offs again.
Right. Okay, third and final pineal approach. The posterior transcallosal approach. When is this one indicated?
This is reserved for tumors that are clearly extending upwards, maybe through the splenium of the corpus callosum itself, or for lesions that are primarily located within the atrium of the lateral ventricle, essentially. Tumors that are definitively situated above the level of the vein of Galen complex.
How do you get there?
Through a parieto-occipital approach, working down the posterior interhemispheric fissure between the two hemispheres, aiming for the splenium. You have to be very careful to preserve the bridging veins draining the cortex into the sagittal sinus, especially those posterior to the central sulcus.
And the key step.
The incision is actually into the splenium, the very back part of the corpus callosum, dividing it right in the midline. Sometimes you might extend that cut into the hippocampal commissure just below it to get into the lateral ventricle if needed.
But the goal, regardless of approach,
Is preserving those deep veins, especially the internal cerebral veins. That remains the absolute top priority in all pineal region surgery.
let's make this concrete. The source material provides two cases that illustrate these choices perfectly. Case 1.
Right, an 8-year-old girl. Classic symptoms of hydrocephalus: headache, ataxia, vomiting. Imaging showed a mixed signal pineal lesion that also involved the right posterior thalamus. Importantly, a diffusion-weighted MRI was negative, arguing against a highly malignant tumor early on.
Imagement.
Staged approach. First, ETV to treat the hydrocephalus, plus an endoscopic biopsy. That confirmed a pilocytic astrocytoma, a relatively benign glioma, because the imaging showed the lesion was primarily below the main venous structures.
They chose
The supracerebellar infratentorial approach for the definitive resection. And the outcome was excellent. Gross total resection discharged quickly, ataxia improved significantly. It's a textbook example of when that approach works beautifully because the venous anatomy was favorable.
Okay, case 2.
A 5-year-old boy, also presenting with hydrocephalus symptoms, drowsiness, papilledema, irregular enhancing tumor. Critically, his tumor markers, AFP and beta-HCG, were negative.
Meaning it wasn't likely a standard germ cell tumor, so biopsy was essential.
Exactly. Emergency ETV plus biopsy, which confirmed a mature teratoma. Now, the source notes that based on the tumor's shape and apparent adherence on imaging, the surgeons opted for the right occipital interhemispheric transcallosal approach for the main resection.
And the outcome? Any issues?
They achieved gross total resection. But there was a transient complication. The patient developed Parinel's syndrome difficulty looking upwards for about 3 days after surgery. This was attributed to the tumor being stuck to the tectal plate, the midbrain roof.
So a temporary neurological deficit related to the approach and the tumor's location.
Precisely. But it resolved, and he was ultimately discharged without any permanent neurological problems. This case highlights how tumor characteristics, like adherence, can push you towards a specific approach, even if it carries slightly different risks, like temporary issues related to working near the tectum.
These cases really drive home the complex decision-making involved. It's all about weighing the tumor's location against the venous anatomy and potential functional risks of each corridor.
Absolutely.
Okay, let's try to consolidate a mastery checklist for our listeners. Key takeaways and hazards.
Good idea. First, burn that anatomical alignment into your brain. Facial colliculus abducens nucleus level in the fourth ventricle floor lines up with the dentate nucleus level in the cerebellum, your internal GPS.
Second, external landmarks matter. Defining the transverse sigmoid junction using the Asterian as your guide is step 1 for a safe retrosigmoid craniotomy.
Third, the absolute safety rule for posterior fossa surgery. Drain CSF from the cisterna magna before you mobilize the cerebellum. Prevent that stretch injury to cranial nerves.
Fourth, for the pineal region, it's all about the veins. The tumor's relationship above-below displacing to the ICVs and vein of Galen dictates your surgical approach, period.
And finally, the critical no-go zone. Avoid dissection in the interpeduncular cistern whenever possible. The density of perforating vessels and the oculomotor nerves makes it incredibly hazardous. Risk of catastrophic vascular injury is just too high.
We've covered a massive amount of incredibly detailed, high-stakes anatomy today, from the eloquent floor of the fourth ventricle and the mechanisms behind PFS, through the CPA, the midbrain entry zones, down to the medulla, and finally into that venous labyrinth of the pineal region.
It's a lot. But this level of granular detail, understanding these corridors, these safe zones, these hazards, It's what's required for elite-level performance in this field.
It truly demands mastery.
It does. And maybe here's a final thought for you, the listener, to mull over. We talk about how crucial advanced imaging, like diffusion tractography, has become for mapping functional pathways and defining safer routes.
Right.
As these imaging technologies get even better, higher resolution, maybe even integrated into surgical navigation in real time,
Yeah.
how much further can we push the boundaries? How much more precisely can we define these safe entry zones? And what might that mean for the difficult surgical trade-offs, like the current risk of PFS, that still define neurosurgery in these incredibly critical, deep parts of the brain? Will technology eventually allow us to minimize those trade-offs even further?
That's a fascinating question for the future. It really highlights how this field demands not just anatomical knowledge, but constant adaptation to new tools and a profound respect for every single millimeter being operated on.
Couldn't agree more.
Thank you for joining us on this very deep dive into the surgical anatomy of the brainstem and pineal region, the true inner sanctum of the central nervous system.